Good afternoon, everybody. My name is Dr. Melissa Stiles, Director of Faculty Development for the department, and I'm very pleased to have the forum today to highlight some of the wonderful research that we do in our department. So Dr. Randy Brown and Christopher Nicholas have joined us to talk about the program for research, outreach, therapeutics, and education in the addictions. Dr. Brown has been with us now. I was looking up, Randy, 20 years. I came in 2001, came to participate in the NIH Primary Care Fellowship, went on to get his PhD through the UW Department of Population Health Sciences, and has been instrumental in really building this program and an example of using the research, but both in the clinical realm, through policy, community engagement, and education, notably being the director of the American Board of Addiction Medicine and president of the Addiction Medicine Fellowship Directors Association. Dr. Christopher Nicholas earned his PhD in clinical psychology and neuroscience. His research really focuses on the clinical efficacy and therapeutic mechanisms of psychedelic and psychoactive compounds for addiction, trauma, chronic pain, and depression. So we're very happy to have you both, and I'll let Randy start it off.
Great. Thanks, Melissa, and great to be here and talk to you all a little bit about some sampling of the work within the program. There's a fair list of things in which we're involved, and I hope by giving sort of a broad overview of that may develop some interest in some of the things we're doing by way of education and research, and that we can, answer some questions and talk about some things in a little more detail. So we were quite intentional about the selection of PROTEA as acronym. And some of you may have heard of PROTEA. It's actually a flower, and it's native to some areas with some fairly harsh conditions. And actually, it tends to thrive in terms of germination after the conditions brought about by a fire. It's a flower that's symbolic of transformation and courage. And so I think, in thinking about addiction and recovery and the reduction of some of the harms attributable to alcohol and other substances, you can probably already find a bit by way of interesting metaphor contained within that background on the flower. There's also all kinds of other interesting tidbits around etymology and mythology related to the Greek god Proteus, from whom the flower's name is derived, but I won't belabor those points. I've provided the link to our website for the program where we provide a little bit of detail about some of those interesting historical tidbits and indicate some of the things that we strive to do within our program here. My training background being what it is in family medicine, I really sort of, and, my training in population health, that's really the set of lenses through which I look at a lot of these issues by way of having gone through my training, seeing that, kind of the compartmentalizing of prevention and treatment in a number of aspects as it comes to substance use disorders is probably a situation we should be working to improve. When it comes to healthcare generally, the other parts of society touched by this, including, say, criminal justice, law enforcement, other prevention services, and public health. This really is an issue where we all need to be contributing to the fight, because it's a problem that's been with us for centuries and isn't going to go away anytime soon. And as many of you may know, we're starting to see all signs pointing to the pandemic contributing to or being associated with increasing concerns along these lines, specifically, for example, opioid overdoses and methamphetamine use and likely alcohol use as well. So what I want to talk about here, I know this is quite busy here, but I put it up just by way of illustrating these different fronts contained within PROTEA. including research or outreach, kind of community-based programming or community outreach programming. Therapeutics, referring to the clinical venues in which we work and provide care, and the educational efforts in which we're involved. And I'll be focusing, given our forum today, on a couple examples of our research efforts. And you can see a bit of the laundry list here. We're most active, internally in two lines of work generally when it comes to research. One being that more health services, public health line, where we're looking at systems approaches and systems improvement to try to get us to a place where general healthcare and community agencies and organizations are interfacing with substance-related issues more effectively. And the other line being in the last 10 years or so, the interest that we've developed in clinical trials with psychedelic, in air quotes, substances, including MDMA and psilocybin, where there have been some really exciting early results with the supervised administration of these compounds in assisting in the treatment of some really challenging conditions for patients and for providers, sometimes including some of the addictive disorders, and I'll be talking about a particular study shortly, PTSD, MDMA, among other things. And I also want to call out some of the organizations and shops that are supporting us in this work, including our own Department of Family Medicine, whose small grants program is supporting some of our work, for example, with the psilocybin study for depression, supporting some work with Dr. Nicholas specifically, who also, in addition to psychology, has background in neuroscience and functional imaging, in which there's a lot of interest in terms of trying to develop some mechanistic explanations neurobiologically around how some of these substances might be providing their therapeutic benefit after fairly limited occasions of administration, one or two in most of these studies. Our health services and implementation work, I'll be talking a little bit more about by way of an example of some of our work, the STOMP study, or Screening and Trauma for Opioid Misuse Prevention. I also put up this Vivent Health study. We do quite a bit of engaged work with Wisconsin's mobile syringe service program to interface with people who inject and engage in efforts to ensure their ongoing safety and connection to care for their use disorder and when they're ready to take that, or for prevention and treatment of, for example, bloodborne infections like hepatitis C and HIV and the like. I make mention here also of Dr. Quanbeck, Andrew Quanbeck, also in our department, with whom we collaborate extensively and who does wonderful work around systems interventions to enhance care along a number of lines clinically relevant to family medicine, but where we've collaborated a lot around enhancing care delivered in general medical settings around use disorders. I won't belabor points around, our outreach efforts, but I've put up some links here for those who are interested in some of the programs that we run to foster provider education in some of these areas, including our ECHO project, a monthly teleeducational session where we discuss cases from primary care settings around different use disorders. And we have sort of experts come in, as well as primary care providers from around the state, to talk about those clinical situations and assist providers in management. Providers should also be aware that in calling the UW Access Center, you can get access to an addiction medicine specialist at point of care to get advice about patient management. We also do the data waiver training for individuals looking to get that currently required, maybe not for long, certification to prescribe a medication known as buprenorphine to assist in recovery for opioid use disorder. We're also doing a lot of work in our rural communities where access to specialist resources can be a real challenge to try to support primary care, as well as peer support models to move folks where they need to be safe. I would be remiss in not thanking the enormous group of people in the department that help on all of these fronts. And so just want to call some of them out here. You can see our faculty group up top that include myself and Dr. Nicholas, and some fairly new faculty members with our addiction medicine program in PROTEA, including Drs. Egan, Dr. Salisbury Afshar, working in our various clinical sites for patient care, as well as teaching our addiction medicine fellows, and Amy Perrins from the PA school, who came onto our clinical team recently and has been a wonderful team member on our consult service at the hospital, and sort of creates bridges with the PA school for our educational programming and making sure those health professional trainees are getting some exposure here. And you can also see our research team members. Bree Dio, I am sorry to say, will be leaving us shortly. She's gotten a really great opportunity with one of our sponsors, the Multidisciplinary Association for Psychedelic Studies, that sponsors pretty well all of the international multi-site trials of MDMA for PTSD, moving toward FDA approval of the supervised administration of that for that indication. Also, particularly want to thank Heather Williams, the coordinator for our Addiction Medicine Fellowship, who keeps that on track. Addiction Medicine Fellowships are quite a recent innovation, having been recognized as a specialty by the American Board of Medical Specialties only 5 years ago, and these training programs only being eligible for formal ACGME accreditation since 2019. So it's been quite a steep learning curve kind of on our front with training to make sure that we're delivering the quality that ACGME asks of us, and that's going to produce the highest quality fellows to deliver this care in a variety of settings. And you can see our current fellows there who are engaged, of course, in their own clinical training, but are also contributing to some of our scholarly work that I've talked about a little bit, and I'll talk about a couple more examples as well. I also have on our screen our facilitators, and those are individuals who play a really key role in our psychedelic studies. And I'll talk a little bit more about that specifically, but these are people who are present with study participants during their dosing session to provide support during that session, but are also engaged in a lot of activities leading up to that and thereafter to help them anticipate the setting and what they might expect, and as well as collecting information about their experience. Our outreach staff, you can see here, Kathleen and Nada, that do a lot of the heavy lifting with our ECHO model. And then Matt, I have to thank, you're here today as well, who we call on quite frequently and is a huge help with all of our outreach efforts by way of the data waiver training, and ECHO, particularly during these days of the pandemic, where we've had to deliver so much of our educational programming virtually. While those are sort of our core people within PROTEA and within the Department of Family Medicine and Community Health, another really rewarding aspect of the work we do is connecting with other people at the University of Wisconsin and beyond. They're doing similar work or complementary work, and this is a handful of those individuals: Charles Raison in the School of Human Ecology and Paul Hudson in the School of Pharmacy, collaborating on our psychedelic trials. We do a lot of work also around mobile health applications to support recovery, and a lot of the thinking and heavy lifting behind that comes out of the School of Industrial and Systems Engineering, and is some really fascinating work by way of supporting individuals in recovery through the mobile application, as well as collecting information around, how they're doing in terms of their substance use and functional status and well-being. We collaborate a lot with infectious diseases. Dr. Westergaard, whose name you may have heard recently, more in association with his role as Chief Medical Officer with the Department of Health Services in the face of the COVID pandemic, and his program manager, Wajia Akhtar, where we're doing a lot of work with their shop that's complementary in terms of hepatitis C, HIV prevention and treatment, particularly in our rural communities, again in collaboration with Wisconsin's Mobile Syringe Service Program. through Vivend Health. Another new faculty member, Majid Afshar, has been a wonderful collaborator early, has NIH-funded work around using the electronic health record and natural language processing to identify language that we put in all of our notes that might be helpful when used in algorithms to potentially identify early patients that might be at risk for developing use disorders down the road. And he's really focused a lot of that work on inpatient settings and ICU, so that maybe we can enhance our screening and intervention practices at that point of care, since use disorders or at-risk use are so highly prevalent among hospitalized patients. Also collaborate, obviously, with GI. We're working on setting up a new clinical setting with some research possibilities with individuals struggling with alcohol-related liver disease. Really excited about the work, relatively recent collaboration with the Division of Extension. If you aren't familiar, UW division that has offices in every county of the state, works with coalitions on the front of our greatest interest of preventing and treating use disorders and trying to get evidence-based knowledge out into those communities. And then Funmi Abraham, who does a lot of work and with whom we collaborate on gaming interventions for adolescents as educational tools to help with their sort of literacy around medication handling and prevent particularly controlled substance use with a focus on prescription opioids. So that's a lot of stuff. So I thought I'd just present a couple examples of recently active work, ongoing work, and then, particularly focus a bit on one of our psychedelic studies, and then let Chris take a deeper dive into that, because he's really doing a lot of the heavy lifting where rubber meets roads on the subject interaction and getting people comfortably through some of those protocols. So one of our health services studies that I mentioned, screening and trauma for opioid misuse prevention, completed data collection here a couple of years ago. We presented in a number of forums and have a manuscript under review with primary results. It was fascinating to work on. I was approached by a nurse practitioner at the hospital who knew kind of my clinical work. And the nurse practitioner on the trauma service had the question for me, Dr. Brown, I really wonder to what extent on our trauma service we may be contributing to addiction with opioid prescribing. And I thought, wow, I wonder, that sounds like something we ought to take a look into. And so with the help of the trauma service, we recruited 295, and orthopedic services, we recruited 295 individuals from UW Hospital, collected a variety of measures that we thought might be putative markers of risk for opioid misuse down the road, and followed them up for 6 months to get a sense of what sorts of items might be worthwhile to screen for while someone in this circumstance, being admitted for a traumatic injury, receiving opioids. If there might be some screening processes we could develop and pilot to reduce that risk. And we did get some signal that was quite strong around symptoms related to anxiety and pain coping. A couple of items that come out of a PTSD screening measure. And we're still, in future projects, going to be taking a deeper dive into what precisely that means, because again, these are screening tools. They're not diagnostic. Does this mean that PTSD is associated with this? We can't say that with 100% certainty, because of course there's some symptoms of PTSD that bear relationship to other anxiety disorders, but the predictive value is quite strong here. And for folks not familiar with receiver operating curves, what you're wanting to see is an area under that curve as close to 1 as possible, with 1.0 being a perfectly sensitive and perfectly specific test. And where with prediction for the development of opioid use disorder, we got to about a 0.97, which is pretty strong when you consider, say, area under the curve for commonly recommended health maintenance activities such as mammogram are closer to the 0.6 range so far as area under the curve. So we're pretty excited about that result and the impact that this work might have down the road. By way of an example, one of our psychedelic studies, where we just did our first participant last week, the study became active, so we're pretty excited about that. And as I describe it, if in your own practices you have folks you think might be eligible or interested, I'll give you some information about that. Many of you likely know that currently recommended treatments for opioid use disorder include medication. And that's really beyond a shadow of a doubt. We know that medication saves lives, particularly when we talk about methadone and buprenorphine. There's less certainty around that for naltrexone, which is the opposite of an opioid or opposite of heroin or morphine, in that it blocks those receptors and keeps heroin or morphine from being active. We don't have mortality data around naltrexone, but while these are highly effective, there are still some real challenges around folks continuing in treatment and maintaining recovery. And so we're interested in seeing whether the subjective experience and protocols associated with administering psilocybin might foster that treatment engagement through other ways, might foster reductions in use and well-being more generally. And so in this preliminary study, while we initially proposed a randomized control efficacy trial for this, as others and us were thinking about it, we felt it worthwhile to do a preliminary study, just seeing how psilocybin and buprenorphine behave together. And so we're recruiting individuals who have a history of opioid use disorder or opioid addiction, but have been stable on that medication, Suboxone or buprenorphine, for 6 months or more. And they're receiving psilocybin, again, under supervised conditions in a dedicated dosing room in the School of Pharmacy. And we're watching for things like, are they experiencing any symptoms of withdrawal, or are they feeling foggy, like their buprenorphine level might be going up, and things along those lines. Honestly, based on animal data, what we tended to expect with this is that buprenorphine might interfere with the potential subjective and therapeutic effects of the psilocybin. And that's where we thought a study like this would be important, is to sort out, might someone in this situation need a higher dose in order to achieve subjective effects and therapeutic benefit. So we're looking to recruit 10 individuals. And if you're interested in more information on this study, it's publicly available on clinicaltrials.gov. And that's the study title you can see there. If you get to clinicaltrials.gov and just search psilocybin Wisconsin, it's going to be one of the very, very few things that come up. So if you're interested in that, and individuals interested in finding out more about your patients or others, can get that information there, and it has contact information about the study. So I wanted to talk a little bit about what these kinds of studies look like, because when we talk about research around psychedelic therapeutics, there can be kind of a reaction around, oh my gosh, those things, I think they're habit forming, and I think they actually could be dangerous. And what are you really doing when you're talking about a clinical trial that involves MDMA or psilocybin? And there is a pretty structured protocol for it in terms of the orientation that I've already made mention of. There are facilitators, lead. Subjects will generally have 6-8 hours of preparation, and then sessions that are termed integration after the dosing session itself, to help them more thoroughly process their experience and potentially enhance its therapeutic value. So this isn't sort of, as I speak about moving toward FDA approval, which is moving rapidly. FDA has given breakthrough status to supervised psilocybin for the indication of depression, and MDMA for the indication of PTSD. You know, we're not talking about arriving at a day where a provider writes a prescription for a fistful of MDMA or psilocybin and say, go forth and treat yourself. The idea is to have approved this platform of supervised administration and these other things that go along with it to enhance safety as well as the likely therapeutic effect. And when the product is delivered, it's traditionally being given not in sort of a clinic looking room, but a more comfortable sort of environment. And this is a picture of our session room in the School of Pharmacy where that magic happens. Just to give you a sense of sort of what this environment, should look like for these studies. So for this particular study with opioid use disorder, we're going to be doing 2 supervised sessions. Again, had our first last week, keeping an eye on measures that I've already alluded to some extent here. And then we have them overnight on the clinical research unit at UW Hospital for monitoring, and then they can have their on-site, so it's more convenient for them to have their integration session the day after, or for purposes of the imaging studies can get imaging done the day after. Or I believe that's the plan, Chris. Here in a minute, you can probably correct me on that needed. And on the short tails of this, we actually do have funding to do the randomized controlled efficacy trial in the setting of opioid use disorder, but want a little bit under our belt by way of this initial phase 1 study, looking at interactions before we're going that direction. So, and there's, as I was saying, still a lot of work to be done, and a lot of things that are important by way of addressing use disorders and associated issues in our community. So we have a number of things kind of in the hopper that we're hoping to build on, including following up, as I mentioned, on an opioid-related screen in the setting of injury, doing more work in rural areas where substance use is no less a problem than in our urban areas, and a few other things that I've listed here around alcohol use and our psilocybin studies. But I want to stop there to make sure we got time. And Chris, wonder if you want to talk a little bit more about the psychedelic work and maybe particularly an upcoming study that I mentioned on here.
Sure, thank you, Randy. Yeah, so there's the field of psychedelic science has just grown over the last 10 years, but more prominently over the last probably 3 or 4. And our team has serendipitously in some ways, but also through our own efforts, been able to make connections with getting funding for these trials from nonprofit and also some industry partners, which we just formed a contract with. But so and also we have funding from the department as well. Right now, NIH will not, they haven't yet funded these trials, although there's some rumblings that NIMH and possibly NIDA will be on board to fund mechanistic studies in the next year or two. So luckily, we'll be well positioned with our data, with opioid use disorder, potentially with methamphetamine use disorder, to have preliminary data for some federally funded grants. Randy, you can tell me when we can pivot to another topic, but because I'll talk the rest of the time on it. Yeah, so with one of the studies that we're excited about is one we received a small grant from the department on, and it's focused on looking at the mechanisms of change, pre-post psilocybin. Right now, we know that psychedelics can, they have a pretty widespread change or induce widespread changes in the brain acutely when one takes a drug. When you intravenously administer psilocybin, you see massive changes in connectivity in the cortex and the cortex connection to the limbic system. But we don't really know how those changes relate to behavior change later on, and if there's any long-term changes from that acute experience. So one of the studies that we'll be doing is doing pre-post functional magnetic resonance imaging after psilocybin in patients who have a major depressive disorder. And what our hypotheses are is that, we think subjectively that the psilocybin increases a state of psychological flexibility. We think there's some biological reasons for that, and then, related psychological reasons for that. And so we've come up with a cognitive flexibility task that a participant will do before they have psilocybin, and then they'll do it after. So we can see which brain changes correspond with potential improvements or at least changes in psychological flexibility after the session. And, if you can imagine, if you're more psychologically flexible, you're more open, you're more curious, you'll be less impacted by maybe more rigid ideas about yourself or behaviors or beliefs that you have. And you can see where that could potentially translate as a positive thing for addiction, depression, and other mental health diagnoses. So that'll be a first in kind. No one has explored this question yet. And another novel aspect of that study is that not only will we be doing a scan after the psilocybin, within a week after, we're going to do another one 6 weeks after. So we'll also get to see if these changes, exist, over a longer time frame, and which I think is going to really help and contribute to the science, because it's really interesting that these compounds, individuals will take, have a dosing session for 8 hours, and then they'll have some psychotherapy before and after, though, but they'll have these impactful dosing sessions once or twice, and there'll be these major changes in behavior and functioning. So we're hoping that this study will start to elucidate some of those neuromechanisms. Another study that we'll be doing is we've recently, like I said, contracted with an industry partner to look at psilocybin as an adjunct for treatment for methamphetamine use disorder, where right now there are behavioral treatments and pharmacological agents, there really aren't that many options there. So very similar to our opioid study, we'll be doing a single arm open label study looking at the safety and feasibility of psilocybin for meth. And another recent, I think, development that's worth talking about is our efforts on this multi-site trial for MDMA-assisted psychotherapy for severe PTSD. We were part of 15 sites, or working with 15 sites across the world, looking at how MDMA, just 3 sessions of MDMA-assisted psychotherapy can be a treatment for severe PTSD. These are individuals that have had PTSD on average for 10 years, have tried multiple treatments and failed. And, results have come in, and we've now submitted. Our team was actually asked to contribute, to make a major contribution to the manuscript, for the multi-site manuscript. And it's now under review. But what we found was that the effect size for this treatment, and this was compared to an active control, almost doubles the gold standard for, what's out there for treating PTSD. And what's even more interesting is that even these gold standard treatments, there's up to almost 40-50% dropout in those treatments. And in this trial of 200 individuals, there was 0 dropout in the treatment group, and only, I think, less than 5% dropout in the placebo arm. So I think that's really encouraging. And, this treatment has been, labeled as a given breakthrough therapy status by the FDA. And, we're hoping that, this trial, and we're doing now a confirmation trial, we're part of that, will hopefully allow this treatment to be approved, as a prescription, where people will have this full package of treatment where they can get it in a clinic under supervised conditions like Randy described, hopefully in the next couple of years. So we're really excited about those efforts. Thank you.
Yeah, great. Thanks a lot, Chris. So yeah, I think we started at 12:15. Actually, I was watching the clock and thinking this forum was over at 1 o'clock. Melissa, is it 1:15?
1:15, correct.
Hard stop.
Yes.
Great. So yeah, I think we can open it up for questions or comments there.
Well, there is one comment from Dr. Gervais. Can you comment on patients with bipolar or risk of triggering bipolar disorders with the psychedelics?
Yeah, Chris, you'll be able to field that more thoroughly than I can, but that's actually one of the contraindications in studies currently. But Chris, maybe you can talk about that in a little more detail.
Yeah, no. So we currently screen out anyone with a family history of bipolar 1 or 2, or obviously, and the participant can have a history of that as well. Although I just read that there is a site that's going to be exploring psilocybin for bipolar in the next year. So I assume they're going to have conditions set up to where they can safely administer it and monitor outcome there. But the convention thus far has been to screen individuals out with this diagnosis. I'm not aware of any outcomes where that has induced any sort of mania or other symptoms associated with bipolar disorders, at least in these controlled trials. And that's because, again, there's quite extensive, comprehensive psychological and medical screening that occurs before anyone could be eligible to enroll.
Great. And if participants want to put questions either in the chat or raise the hand, get to everybody's question. Maybe Chris, you could comment on how long-lasting the effects are for the trials that have been done, the one you commented on with PTSD, and then also for depression.
Yeah, so I mean that data is we're still accumulating data on that front, so we do see behavior change. I mean, there's an interaction between dosing effects, the condition itself, how long, what is subset of that condition, right? So we may see longer therapeutic trajectories for individuals who have more mild or moderate forms of said diagnosis, but so far, what we see is that the actual acute effects of the drug itself last about 8 to 10 hours. But then after that, there are, scheduled therapy sessions to really help people make sense, integrate, and learn, and translate what these new insights and experiences from the dosing session, translate them into actionable behavior change. So it's sometimes hard to tease out what is actually the effects of the drug versus, the interaction with the therapy as well. Earlier data has shown that individuals with life-threatening or who have terminal cancer diagnosis, that they will show, positive changes in depression, anxiety for over a year after 1 or 2 doses. Another trial showed in tobacco cessation, which is really interesting. This happened in Hopkins. This occurred in Hopkins, and they just finished a randomized controlled trial where and what they found was that basically after a year after 1 or 2 doses of psilocybin for individuals who have tried other methods for ceasing tobacco, that over 66, almost 70% of that sample was still abstinent from tobacco afterward. So that's amazing effects in the tobacco cessation world. So it really depends on the condition, but we are seeing these lasting changes. So there's really, there's potential here to do economic analyses on this treatment to see if this not only has, therapeutic change or a benefit, but also can, from a healthcare economic perspective, have benefit there as well, if we can, administer these compounds in only, a handful of sessions.
And someone had asked about links for the different studies. I'd put up the one for the opioid use disorder study that I'd mentioned, but Melissa, if I send other links to you, or how would be best to get info out to the full group?
Sure. You can email Sue McGuire and she'll send that
Sue,
link for
okay,
the
perfect.
recording.
All right.
See, Randy, could you comment on outreach or statewide advocacy on this issue? And are there things that the group can help in terms of advocacy for any policies that are coming up?
I'm sorry, I missed part of that, asking about policies particular to, sorry.
To Wisconsin, or if there's anything that the
Oh.
group should be aware of, or how we can advocate on wider usage, wider outreach, and monies into opioid addiction.
Yeah, well, yeah, I mean, one of the things that's going to be a bit of a moving target is regulations were relaxed to some extent around initiating treatment for opioid use disorder with buprenorphine, to some degree with methadone in those federally and state licensed treatment settings, where a in-person visit wasn't required, where normally previously, before a controlled substance was prescribed, that was a requirement. And the extent to which there's still going to be ability to do that, whether telehealth is going to be something that will continue to be reimbursable to facilitate that care going forward, particularly in areas where access to resources is really difficult, I think is something to keep an eye on, because again, we're probably looking at a year last year that's going to tragically break all records in terms of opioid related complications and overdose and mortality. So that's one thing.
And congratulations, we'll miss you. Just hearing about your new position, but he's put in some links to studies for both PTSD and then also for major depression.
Okay. And someone had asked in the chat, opioid use disorder tendencies in patients, wondering about use in the ER. And that's something that we've thought a lot about so far as potential future work, and certainly would seem, an applicable setting to be doing that. In part, it wasn't done in the context of this initial STOMP study, just due to logistics with running a study and gathering information from patients in that setting, since the turnaround is more rapid, and where, really honestly, you'd think that there was more out there in the literature around characteristics of patients who sustain a traumatic injury requiring hospitalization that we should watch for to prevent misuse of opioids, but there really isn't. And so that's where, in this study, we thought we really need to take a step back and do that initial work before proposing a screen, and doing it in that controlled environment, a hospital where people were around for a little longer and we could gather more information, is sort of the stage that is where we are. But definitely feel like moving that into the emergency department setting and figuring out not only what is the screen, but how can it fit into workflows is an important set of questions.
And question by Dr. Bill Hefner, still tending, to see people come through post-hospital stay with wanting refills for high volume opioid prescriptions. And wondering if, I think, particularly with orthopedic or trauma surgery regarding opiate dispensing, and if there's any work with that in terms of guidelines.
Let's see. Staff. Yeah, and this is also a place where the needle is going to be moving. Another really, and that's actually another active area of work of an investigator in the Department of Surgery, is around opioid prescribing post-operatively. There's certainly been a lot of institutional movement in many locations around what that volume of opioid prescribing is, and should it be more standardized with less disparity in what that looks like. Another area where, we don't know precisely what that should look like, and in many cases needs to be clinically individualized. But, systems are certainly doing things like changing the default on number of opioids that are prescribed so that when you click on the button, it isn't 180 oxycodones and things like that. But it's definitely an area where we don't really have best evidence to tell us, oh, you just had a femur fracture that required surgical management. You should get this many oxycodones. You just had urological surgery. You should just get this many oxycodones. That, it kind of complicates things.
Yeah, and I think I've also seen situations the other way where I had a friend who had come back, had a fracture in a different state. And so we're seeing the orthopedic surgeon here for the first time and follow up, and absolutely did not, would not prescribe any refill, any narcotics at all. It was just an absolute, I'm not going to do it. So,
yeah. And as we've gone through this study, I mean, the other thing that I've learned a lot about is, what this flow looks like, and there's going to be more work to do on that front, because typically patients will have one visit, maybe two, with orthopedics or trauma, and then who's taking over? It's primary care, right? Mm-hmm. And how should that handoff look, and how should that ongoing prescribing look, and that care coordination, can be a challenge. And again, what that prescribing looks like is gonna vary. For example, a pelvic fracture, trauma surgeons, orthopedic surgeons are not surprised at all if somebody is taking opioids on some sort of basis for 2 months, 3 months. As opposed to, say, long bone fractures and things like that, but some of that care coordination is another interesting set of questions, with STOMP. That was another logistical consideration with the study is, we've got an audience that's more or less captive in the hospital, but is that really where the screening should be happening? I think that's still a question. Is that something that should be happening, after? Maybe there's some role for it in the hospital, but maybe something along those lines needs to be done, in the setting of trauma surgery follow-up, or maybe, with that initial primary care visit. There's a lot of questions that we don't have perfect answers to.
I was curious, talking about the international collaborations. Are there countries that are further ahead with their research and integrating this into treatment options?
Well, yeah, I mean, the United States is in a little bit of a strange situation when it comes to communication between systems about substance-related issues. 42 CFR Part 2 is this federal statute, and there are analogous state statutes creating requirements around highly confidential handling of information related to substance use disorders when delivered by agencies who are funded specifically to do that. And so it creates some real challenges, I think, obviously, by way of coordination of care and by way of general medical settings, knowing what's happening with the patient and how best to provide their care and support them. And other countries do not handle it that way. And even, within the United States, the VA, for example, that information is all available. The argument for that confidentiality, as you might imagine, is there's stigma attached to seeking that treatment. People won't seek that treatment if we tell them that information is out there in their medical record or available for their employer to see or what have you. So. In methadone, for example, I talked about opioid treatment programs, how strictly they're regulated. U.S. is the only country that handles that particular medication in that way. Primary care is prescribing methadone, in the UK and Australia.
Mm-hmm. Yes. I'm sure I'm not seeing anything. Anyone? These just questions. Or unmute or put them into the chat.
Oh, Bree, in Canada, providers can prescribe heroin. Yeah, that happens in Switzerland as well. I think there are probably a couple other countries doing that. I don't think that's coming our way anytime soon. One progressive item that may be coming down the pike in the United States is medically supervised injecting centers. And that's been considered. I don't know if it's been established for sure. It was either New York or Boston that was moving forward most quickly on that. That's a site where it tends to target places where there's been a lot of public injection, public overdose, homeless or unstably housed individuals are well served by these facilities where people can bring drug, medical personnel are present so that if they do, they can get clean, sterile supplies. If they do overdose, there are personnel present with the expertise to intervene appropriately. But
interesting. A question for Chris on kind of what you're kind of looking to the future. You ever see this integrated into primary care, this type of treatment, and how you look at this? If the research is successful, what would the vision be?
Well, I think the vision at this point, that's unfortunately probably a long way for psilocybin, probably 4 or 5 years at least, before rescheduling probably, although there are decriminalization efforts, and successful ones at other states so there may be models there to watch. But I would hope that it would be an option that providers can refer patients to, and that there'll be clinics that can provide this care in a way that's either covered by insurance or, in some ways accessible financially. That's a big question right now, is with all the staffing, like you have an 8 or 10 hour session plus all the preparation and integration, that's a lot of clinical hours. And how do we reimburse someone for their time with that, but also make it affordable and accessible? And there's a lot of people looking into that question. Even though that's still a ways off, it's still an important thing to get ahead of.
Great. And thanks, Bree, for putting more information in. And I'm not familiar with the OUD, what the T is for OUD waiver training.
Kathleen on Dr. Brown's team.
Hi, Kathleen.
Outreach coordinator. Hi. I was just trying to put information quickly. We do have a treatment of opioid use disorder waiver training scheduled for next week.
Wonderful.
We're still taking
Great. So, interested, please email Kathleen. Great.
And I think another thing we'll be putting on, a lot of providers will go through that waiver training and get that certification to be able to prescribe that. But a lot will kind of feel like, boy, that was good information, but doesn't quite feel like enough to really get that up and going in my practice. So we're also doing something in May we call a buprenorphine boot camp, where we do a bit more by way of case-based learning and discussion of topics particular to engaging in that practice in a primary care setting. Because the data waiver training is quite, high level, and pharmacokinetics and pharmacodynamics and some of the nuts and bolts. But that'll be another session that'll be available, for folks to sign up for free of charge, on our website too, for May.
Do you have that date yet?
We do, Kathleen. I'm blanking on it.
May 14th.
May 14th.
All right, excellent. So, well, thank you so much. Amazing work you and the whole team have been doing, are going to be doing. So really appreciate you giving an update, and we'll get information out about the boot camp and the waiver training coming up when we send the information with the video link for the presentation today.
Well, thanks a lot for having us. Really appreciate it. Hope it was interesting. And like I say, check on the website and feel free to reach out to one of us if you have other questions about the work.
Sounds good. Thanks so much. Everybody have a nice afternoon.
All right.
Thank you.